Shai Efrati is a physician and researcher based in Israel, where he serves as director of the Sagol Center for Hyperbaric Medicine and Research at the Shamir Medical Center, home to one of the largest and most advanced clinical hyperbaric programs in the world. In addition to his clinical leadership, Dr. Efrati is a professor at Tel Aviv University's Sackler School of Medicine and heads the Sagol Center for Hyperbaric Medicine and Research, where he focuses extensively on brain health, aging, and recovery after injury. His groundbreaking work on what he describes as the hyperoxic-hypoxic paradox has helped reframe our understanding of how hyperbaric oxygen can stimulate neuroplasticity and regeneration, particularly in patients with traumatic brain injury, stroke, and age-related cognitive decline. Today, Dr. Efrati will present powerful data from his treatment of over 400 individuals daily with brain trauma, examining how advanced hyperbaric oxygen treatment protocols can help treat with what he aptly calls wounds to the brain. Please join me in welcoming this year's Eric Kinwall lecturer, Dr. Shai Efrati.
So it's a privilege to be here. I'm going to speak about the collaboration with the IDF, which is the Israeli Defense Forces. But I will start with saying war is a bad thing. It's really a bad thing. The only good thing in war is that it makes everybody involved to get the maximum from what we have. Anybody, the resources, the tool, the knowledge. And even here, we as a medical team, what it makes us maximize the tool that we have. And I will speak about the tools that we have in hyperbaric medicine. When we're speaking about hyperbaric medicine, there are three active ingredients that we can use. We have the pressure, which is one active ingredient, and we will get into that. We have the oxygen, and we also have the regeneration, our ability to induce the repair mechanism. And we will go one by one, and in each one of them, we will touch with respect to combat injuries. Let's start with the first one, the pressure. The indication for using hyperbaric for the pressure is when we have bubbles in the body. We have bubbles, we need to shrink them down because we cannot go after each bubble and look for it and take it out. So the only way we can do it is increasing the pressure, shrinking the bubble, and taking the people out gradually. It's all familiar to us when we are dealing with diving, with the bands, and everything related to that. However, what happened in that war, since October 7, the pilots were, I don't want to say overutilized, but it's probably, that's what happened, overutilizing the airplane. And as we all know, when you are flying above 335 altitude, very high altitude, the cabin is being compressed to 1 atmosphere. And mechanical problems happen, especially when you're overutilizing the pilots. So what happened is that the cabin pressure is been falling down. When the cabin pressure, when you have this kind of thing, usually what the pilot's supposed to do is a fast dive to as low as possible. It's quite problematic to do it when you are on a foreign country that you cannot go down because you will be hit. So what happened during this war that we are in, when that happened, they could not go down, they are flying, we get a call immediately that we should be prepared, they are landing, and the minute after they are coming to our unit to get the treatment. And we treat them with table 6A of the US Navy. You treat them, you shrink the bubble, 2 days after they are flying again. and it happened several times. So this is what we have over here. We didn't have diving accident, but we have airplane accident. This is one thing. Another thing that happened, another reason for air emboli, it's when there is a blast injury, and then the lungs are being collapsed, and then you have pulmonary damage. Air is moving to the circulation, and then you have the bubbles. The standard situation is you take people, you take them into the chamber, you shrink the bubbles, and that's it. But what do you do when you have an injured individual whose lungs have totally collapsed and he's already on ECMO? The first soldier that had that, we said, I don't know how to take an ECMO into the chamber, not the ECMO that we have. But once you are losing a soldier, you are using a lung individual, the next thing you do, you said, it will never happen again. So we found an ECMO device, which is totally pneumatic. It's all machinery, simple machinery inside, and we adapting to that use. And this device, we can take it to 6 atmospheres. So we did it, we take it to 6 atmospheres, and now we can take people with ECMO device inside, so we are not losing any more patients who have pulmonary emboli and are on ECMO. So this is the pressure. The next thing, the next active ingredient that we have is the oxygen. And as we all know, if we want to deliver more oxygen, we need to compress more molecules. More molecules are going per square, more to the circulation in all the tissue that we have in our body. So this is the oxygen. The classical indication, and Lynn is sitting here, is CO intoxication. Okay, the CO is being bound to the hemoglobin, but more than that, it's been bound to the mitochondria. And that's caused metabolic damage. It's caused hypoxia at the level of the cell. So we're all familiar with CO. But since October 7, we have met this kind of thing. These are civilians, the kibbutz that were surrounding Gaza. People were sitting in the safe room in the house. And since the terrorists could not enter that safe room, what they have done, they have burned up the house. And then we got a call from people inside with a cellular phone. They are burning out my house. What should I do? How can I prevent the smoke from going inside? And this was in unbelievable large number. Another kind of CO intoxication that we have, especially on the north of Israel, when the soldiers were in Lebanon, they felt cold. And when you're feeling cold, they took the generator inside the room, activated the generator so they can warm up the net. And then you have a whole group of soldiers who have severe CO intoxication. We also had this because missiles were going over Israel. People needed to stay in the safe room and not go outside. So they take everything they have into the safe room. The barbecue, the nargila, whatever you have, you do it in the safe room. And then you have an unbelievable amount of people who have CO intoxication. Usually in Israel, I must tell you, we are not familiar with CO intoxication. It's a warm country. And then we found ourselves in the question, how many people with CO intoxication we can treat simultaneously if they are on ventilator? It was tough. We couldn't treat it. And I must tell you that on October 7, we collapsed. We couldn't treat the people. All the system collapsed. Our ability today is 2 people on ventilator that we can take inside. But we figure out we need to take it several steps forward. Another interesting indication that we met for the first time was fungal infection, Aspergillus infection. It happens to be that in the sand of Gaza, the spores of the fungal can survive for a significant period of time. And at the beginning, we have few cases of soldiers who had burns, simple burns, they lose the skin. Nothing serious, 5% burn, 10% burn. And when they came to the hospital, an unbelievable thing happened. The the spores, the fungal, spread all over, penetrated the body. And we lost 6 young people, totally healthy, who came just with bones. We didn't understand at the beginning what's going on, what we are dealing with. It happens to be that we were dealing with Aspergillus. And when we had the 7th case, we said, oh my God, we need to change something. And the Aspergillus, the fungal infection that they got in Gaza, was totally resistant to all the antifungal antibiotics that we have. They're resistant because it was probably overused over there. So we lost 6 central. And then we said we have to think outside of the box. How we can fight that? And we figure out that if you take the Aspergillus, the fungal, and you change the environment, you are going 2.5 atmosphere and above, then the fungal stop to replicate. If we are taking it to 2.8 atmosphere, they start to die. And then we have an extreme case. It was from other hospital. I get a call, Shai, what we can do? I said, what do you have? He said, we have a soldier, 21 years old, who came to our hospital with 6% of burns, but we are losing him. He's totally collapsing. He lost all the skin, the fungal is in his liver, in his lungs, in his brain, totally unconscious. We don't have anything to do. He's with adrenaline, ventilator, everything we have, we are losing it. What do you think? I said, bring him on. And to make you understand what we are dealing with, this is what we are dealing with. And it's all over the body. The kidneys malfunctioning, liver malfunctioning, the brain malfunctioning. This is the case. This is the most severe patient in the ICU. And we said we're not going to lose him. And then we took him into the chamber. And think about taking something like this into the chamber. We have a whole ICU unit in the chamber. We took to 2.8 atmospheres. We pushed the limits. We did some calculation of the oxygen toxicity. And we did it a couple of times per day. Arrhythmia in the chamber, instability in the chamber. You can imagine what's going on. And we took him to the oxygen toxicity until he will have convulsion. I said, okay, to have convulsion because we are losing it. And amazingly, after 3 days, and we have 8 people like this, after 3 days, no fungal, totally eliminated. And once we are eliminating the fungal, then you can do skin grafting, the organs start to function. And look at this guy. Yeah. This is the same guy that you saw before. This is him. Okay? And that's what we mean. That's what we do. Interesting in that guy, this guy was in a tank that got fire inside, and his lungs were totally destroyed from the chemical entity, not from the fungal. So what we have done after we fixed all the organs that you saw in the skin, we did a lung transplantation from another officer that died in Gaza because he had direct shot to his head. We took the lungs from this guy and planted it in his guy. And he's living, enjoying himself. You see that? I'm supposed to do a couple of journeys with this guy. And we have several like this. The last thing, or indication, we spoke about pressure as the active ingredient. We spoke about the oxygen, how we use it as the active ingredient. And the last category is regeneration. How we can induce the repair mechanism in a better way. And what do we need for regeneration? There are 4 crucial elements that we need, and if we are missing one, there won't be a repair. The tissue will not heal. One of them is trigger. We need a trigger to induce the repair mechanism. We need stem cells, cells that can proliferate and differentiate into the missing tissue. Of course, we need energy. Energy means oxygen and mitochondrial function. And we need angiogenesis, generation of new blood vessels. That's what we need. If we have all these elements, there is a chance for recovery. If we are missing one, there won't be repair. Let's start with the trigger. What is the most powerful trigger that we have in our body to induce the repair mechanism? The most powerful trigger that we have is actually hypoxia, is lack of oxygen. Because when there is hypoxia, from evolution perspective, the body knows that there is a problem. And I say, okay, I have a problem, let's repair it. And this being triggered by HIF. HIF stands for hypoxic-induced factor. It's a promoter that once it's going up, it will induce the expression of other genes that are responsible for the repair mechanism. So this is HIF. But what is exactly HIF? Let's dig into that. Actually, in the cell, we have two HIF proteins. HIF alpha, it can be HIF 1, 2, 3, depends on the cell where the HIF is, but it's HIF alpha, which is located in the cytoplasm, and HIF beta, which is located within the nucleus. If HIF alpha is not being destroyed, he will go into the nucleus, match with the HIF beta, and now we have an active promoter. And when they are both together, the promoter will go to the DNA and will initiate expression of different genes. What determines whether the HIF alpha that is in the cytoplasm will survive, yes or not? It's based on the balance between ROS, reactive oxygen species, and scavengers. Scavengers are actually protein, and the ROS are actually byproduct of the activity of the mitochondria. It's actually electron that been released during that process. So at normal states, we have a certain balance between the ROS and the scavenger. If we have free ROS, the free ROS will bind to the HIF alpha, and then it will go into a complex that will be degraded, and we don't have HIF alpha activate anymore. This is what happened under normal condition. What happened during hypoxia? During hypoxia, the mitochondria doesn't have the fuel that needs to activate it. And that's why the mitochondria doesn't generate any ROS. It doesn't release any electron. And then we have a change in the balance, where in the balance we have the scavengers. The scavengers are protein. They are not going up and down very fast because the protein half-time is significantly lower than the electron half-life. And then in the balance we have more scavengers than ROS, and the HIF alpha will not be destroyed. He will go into the nucleus, match with the HIF beta, and then we have an active ingredient and HIF will be expressed. So that's normal condition. What happened during hyperoxia? The mitochondria will be overactivated, we will have more ROS, and then all the HIF will be destroyed and we don't have actually active HIF in the nucleus. That's standard condition. But what happens if we are doing repeated exposure to the high oxygen level? What happens if we are doing that is actually we are going up and down, up and down. The amount of ROS will go up. The body will adjust by generating more scavenger. But when we will go back to the normal, the scavenger will stay. However, the ROS will go down immediately. So the net effect will be to have higher scavengers level as compared to the ROS. And this is exactly what's been happening during hypoxia, but without hypoxia. Meaning we are inducing the HIF activation without hypoxia. And this is what we call the hyperoxic-hypoxic paradox. In order to reach that point, we need repeated exposure. It's not enough to do one exposure. Repeated exposure, increasing the ROS. The ROS is a protein. It cannot go down immediately with the ROS. And that's the hyperoxic-hypoxic paradox. In order to do that, we need a control environment. This is the chambers that we have in Israel. This is our unit. You take people inside, you compress the chamber with air, not with oxygen, and then you can simply ask the people to take the mask off and on, off and on. In addition to that, we have the interval between the different sessions, the daily session, which is off period. And what happened when we are doing that? Look at this. These are people that are coming for repeated exposure. This is the baseline HIF. You can measure, we can measure HIF activity within cells that have nucleus, which is the PBMCs. And you can see the baseline. This is after 30 sessions, after 60 sessions. It's not in the chamber. It's before going into the chamber. It means that after 20 to 30 sessions, the outside environment that we are living in now is being sensed as hypoxia even though we don't have hypoxia. It's a new set of the body physiology. And this is the hyperoxic-hypoxic paradox. Once we are doing that, all the body thinks there is a problem. So stem cells are coming up. Stem cells are the cell that's supposed to replace the missing tissue. Whoever generated this body didn't generate this body for a day or two, for a period of time. And he knew that things will happen along the way. So instead of giving us repair because he didn't know what's going to get wrong, he gave us three-dimensional printer. These are the stem cells. He said, print. You're losing skin, print a skin. You're losing a bone, print a bone, etc., etc. So that's the stem cells. What unique to the stem cell is their metabolism. Their metabolism is very, very low, extremely low. They are not active. They are dormant. They are sleeping. Why is that? Because if they had the same activity as the normal cell, so whatever is damaging the normal cell would have damaged also the stem cells. And they need to be the reserve, like a bear. You take a bear, you need to survive the winter, his metabolism is going down. Because if you live like he's in the summer, he will lose it. He will not reach the next summer. Same with stem cells. But once they have a trigger, they get up and say, oh, we have a problem. Now we need to replicate. We need to replicate to generate more stem cells, and we need to differentiate into the missing tissue. And those are the stem cells. And if you are taking people coming to repeated session, you can see the increase in the stem cells. We can measure that in the blood, in humans. In animal models, we can take the tissue out. We are playing a lot with stem cells in our lab. I'm a great physician of mice and rat. I can cure everything in mice. However, in humans, when we are taking the stem cells, the results are not so good, at least not in our hands. And we're thinking, why? Why we are so good in mice and not so good in humans? One of the reasons related to that. If I will take this plant and put it here on the left side, what will happen? Probably not much. However, if I will put it here, it will flourish and grow. When we are speaking about humans, where we have a wound that it's not been fully recovered, usually we have a bottleneck. And the bottleneck, in most cases, is related to the perfusion, to the blood flow. This is normal blood flow, and this is what happens when we have damage to small blood vessels. Whatever happened after this occlusion, this is a desert. You can take the best plant that you have in the world, put it here, it will not flourish, it will not grow. So we need to solve that. And when we are going to hyperbaric environment, and we are going 2 ATA and above, the amount of the dissolved oxygen is sufficient for all the energy demand. And oxygen can go by diffusion even to location where red blood cells cannot go. And this is not a desert anymore. Here they can grow and flourish. Doing that is good, but we need new access road because people cannot live in the chamber. We need angiogenesis. And if we want to think about angiogenesis, the best way to look at the small blood vessels is the eyes. I always said God gave us eyes so we can look at the small blood vessels and see what's going on. And we can take this classical example. This is post-radiation injury given to glioblastoma, and you can look at the eye, And you can see the immediate effect, and this is the long-term effect. This is the destruction of the small blood vessels. This is radiation injury, delayed radiation injury. Here, nothing can grow. When you're taking this and you give repeated session of hyperbaric, and we should say HHP, the hyperoxic-hypoxic paradox, because this is not the pressure, this is not the oxygen, this is the fluctuation that what we generate over here, we can see the angiogenesis. And once you have this angiogenesis, it's different dynamic. It's a different tissue. From here, it will flourish, it will grow, it will repair. So this is that. The last element that we should take it into consideration, it's probably the most important organ that we have in our body. The most important organ that we have in our body is the mitochondria. We have it in each of our cells, and the mitochondria actually is responsible for the energy that the body is using, for the ATP generation. So we should look at the mitochondria and see where the mitochondria is living, what the mitochondria actually sensing. And all the oxygen cascade that start from the lungs, going into the blood vessel and reaching up the mitochondria, it's all the oxygen cascade. The target organ is the mitochondria. Now we all know that in the blood, the arterial bed, we have oxygen level around 100 mercuries. But at the end of the day, what we have at the mitochondria level is between 1 to 4 mercuries. That's it. And if we want to play with that, it's not sufficient to increase the hemoglobin, because the hemoglobin doesn't play with the diffusion gradient. We need to play with the dissolved oxygen that we have in the blood. And this is the privilege that we have in hyperbaric medicine. What we are doing, when we are increasing the oxygen level, we are increasing the dissolved oxygen. And any change that we make in the dissolved oxygen is being immediately inflated on the mitochondria. So we have the privilege when we are going up and down, it's just like doing interval training to the mitochondria. Okay, that's it. Okay, that's interval training to the mitochondria without sweating, which is also great. And once we are doing that, we can see something that we in the past thought that cannot happen. We see mitochondrial proliferation. Amazing. The mitochondria are proliferating. It's very, very easy for us to understand that we have mitochondria on the muscles, but we have mitochondria also in the brain. This is what you're looking here. This is the hippocampus, and you see the mitochondria over there. And once we are doing this interval training to the mitochondria with the HHP, the hyperoxic-hypoxic paradox, we can see the mitochondrial proliferation in the muscle and in the brain. In humans, unfortunately, we cannot take the brain out, not yet, even though every year I'm asking the ethics committee, I want to take a brain out. They say, no, not this year. I said, okay, I will try next year. In humans, we have to use other tissues, like the muscle. So we are doing muscle biopsies. And we have the privilege that we can measure the different complex of the mitochondria. And with this HHP that we are doing, interval training to the mitochondria, we can see that complex 1 is more active. And we can see that we can generate, the efficiency of the mitochondria is better. So we can generate more ATP per glucose. And we can see also the mitochondrial proliferation. So if we are referring to the regenerative capacity, the repair mechanism, we are speaking about the hyperoxic-hypoxic paradox. We are doing that, we are inducing HIF, we are inducing VEGF, vascular endothelial growth factor, angiogenesis, stem cells that proliferate and move into the target organ. That's what we do. So how we take advantage of that on the extreme cases that we have since October 7? Look at this case, for example. This is a soldier, blast injury, came again to another hospital, because the evacuation wasn't necessarily to our hospital. There were too many. They were spread all over. And he became without conscience, bleeding. And this was his hand, his ventilator, as you can see. And the physician came to the parent and say, you know, we need to deal with the other stuff. We will have to cut the hand because we don't know what to do with that. And of course, the mother was shouting, cut the hand, I want whatever left from my child, I don't care about the hand. But the head of the ICU say, 1 minute, I will call Shai and ask him if he has something in mind. So they were calling us, and we saw that, and I said, don't touch the hand, bring him on. And what we are doing is we are working as a team, okay? The hyperbaric physician is leading the team, but it's a team group. Plastic surgeon, orthopedics, all of us work together, sit together, share ID together, fight together in order to rescue that. And look at this. This is just the hand at the beginning. Look what happened. And this is with the hyperbaric because we can keep the tissue alive. And look at this end. We took at the end, we took skin from his leg and implanted here. So he's have functioning hand. Of course, at the end of the treatment, he was terrified because he have hairs on his hand. He said, don't worry, I will take care of that. We will take it off. But this is the kind of thing, this is the kind of the extreme cases that we were called to save and rescue. And indeed today we are doing amazing stuff that in the past nobody would imagine that is possible, and this can happen only in team groups. Looking at the kind of injuries that are being referred to hyperbaric medicine, we can look also from time schedule point of view. So there are the immediate, acute, urgent cases, which is CO intoxication, decompression, and we're not speaking about diving, we are speaking also high altitude pilot. The collaboration is very important with regard to that. It's not classical because in many places it's a separate issue. If we speak about day to 2 weeks, we're speaking about wounds, rescuing a limb, rescue a finger, rescue whatever is needed. We speak about fungal infection. So for the first time, we see young individuals who are not immunosuppressed that are losing their life because of fungal infection. And now we are dealing mostly with this, which is months to years after the acute insult. And here we have 2 issues. We have the post-concussion, post-blast injury, and we have the PTSD. When we are looking at the battlefield today and the kind of injuries that we have, in the past, we used to hit each other with the hands, with the stone. We used to hit each other. That's what we're supposed to be. You have to be strong. And then we had the sword, okay, stabbing each other. We don't do that anymore. And then we have this kind of injury. Rifle, shooting each other. But in today's battlefield, what we have is mostly blast injuries. That's what we have in today's battlefield. And that's where the world is going. And when you're looking at today's battlefield, that's how they look. It's blast injuries all over from different kind of weapon, but it's blast injury. You don't see the enemy anymore in your eyes. You've been blasting him. He's been blasting you. But that's how it looks. So what we are dealing with traumatic brain injury and blast injuries. And if we look at the traumatic brain injury classification, how do we classify traumatic brain injuries? We classify them into mild, moderate, and severe. But look how we classified it. It's ridiculous. How much post-traumatic amnesia do you have? Did you lose conscience or didn't lose conscience? Less than 30 minutes, more than 1 day. It's ridiculous. We don't look at the brain and say, okay, let's see what happened in the brain. This is prehistorical. It's when we have the stones. It's still there. Just to give you a realization of what the battlefield look like. Look at this. This is blast injury. He didn't lose conscience. He's awake. This is mild. Mild traumatic brain injuries. Now look what happened, what surrounds him. This mild traumatic brain injury probably come with PTSD. With, without, in a minute we will get it. But this is mild. Does anybody in this room thinks that this is mild? That's the classification. This is probably his PTSD. That's the battlefield that we have today. So what happened in the brain? In the brain we have two layers. We have the cortex, we have the medulla, different density. The brain is in fluids. So think what happened during this blast. The brain is moving up and down, it's moving like this. If you have force on different mass, the acceleration will be different. The acceleration will be different, and then everything that's in between will tear down. It includes neurons and includes small blood vessels that we have over here. Once we have this, we have the ischemic cascade. And that will culminate in something like 30% of the cases with what we call post-concussion syndrome. 30% or more, we don't know the exact number, but something around 30%, will suffer from prolonged, long-standing neurocognitive decline. What is the main problem with that? We don't see it. We don't see it in a standard CT. We don't see it in a standard MRI. But from our perspective, we have a wound, just like a wound that we have in the periphery. The core elements that are needed to repair a wound in the brain are the basic core elements that we need to repair a peripheral wound that you saw before. What is the main difference between the wounds that you saw in the periphery before and the wounds that now we have in the brain? Is that the periphery wound is tangible. We see it, we smell it. You saw the wound before, everybody understands what we are dealing with. But the wound in the brain? No, this is the brain. We speak about the brain in the mystic fashion. Cognition, personality. It's a damaged tissue. We cannot see it in a standard MRI or in a standard CT. And the most important thing that we did in the first study that we have done on TBI, on post-concussion syndrome, we took people who had post-concussion syndrome for more than a year. Not because this is the classical time to treat, because we didn't want the control group to improve. But the most important thing in this study, and people don't realize that, is the brain imaging. It took us, I think, something like 5 years to optimize a protocol that we can look at the brain in the same manner we are looking at the periphery. And for that, we have took a material. The name of the material is ECD. What's good in SPECT, you can choose whatever you want, whatever tracer that you want. You mark it, inject it, and then you can follow it, and you can see what's going on. So we took ECD. ECD is being metabolized in the neurons, okay, with a certain enzyme, carboxytranscriptase, okay, that we have mostly in neurons and glia cell. It's been metabolized, it's hydrophilic, so it can penetrate the PBB. It can penetrate into the cell membranes, but once it's been metabolized in the neuron and the glial cell, it's stuck because it becomes hydrophilic. You inject it, you give something like 30 minutes, and then take the imaging. It took us a lot of time to optimize this protocol. Sounds easy, 6 years. And then we can have this kind of brain imaging that you see over here. The MRI is normal, so you can see here, this is the temporal lobe. We use colors in order to simplify it to us, so we can see those wounds in the same manner we see the wounds in the periphery. Colors, necrotic, non-necrotic, green, blue, yellow, red. That's what we do. And of course, today we have a sophisticated imaging that we can do fiber tracking. We can see the neurons before, we can see the neurons after. It happens to be that we have stem cells in the brain, in the hippocampus, in the periventricular area. And the same HHP, the same interval training that we are doing with the oxygen and the pressure also trigger the stem cells in the brain. And that's the result of that. We can see neurogenesis. Of course, we do not take the tissue out, so we need to use brain imaging in order to do that. Something is happening in the last 20 years. More and more people realize that indeed the brain is a tissue. And more people realize that we need to approach it in a different way. We need to repair the damaged tissue. So there is more and more studies that publish on the use of the hyperbaric, which is not hyperbaric, the HHP, the hyperoxic-hypoxic paradox, in order to repair this tissue. And Amir is sitting here. Amir have done an amazing meta-analysis on the clinical studies that were done on post-concussion patients. Of course, there are limitations to every study. The most important thing is, how do you choose the appropriate patient? We choose it with the brain imaging because we are treating a tissue, so we are looking for the tissue. But this is the meta-analysis, and you can see 10 articles. There are other issues related to how you measure cognition, which is a whole entity by itself. But to make a long story short, when you are looking at this meta-analysis, you can see a significant improvement in the cognitive function. You can see a significant improvement in post-concussion symptoms, because as you saw, if we are dealing with military-induced post-concussion or blast injury, it's not, in many cases, it's not clear TBI. It's combined with other stuff. We can see also the symptoms of PTSD improving. And to make a long story short, there isn't much intervention like the intervention that we use, the HHP, that is in our hands, playing with the environment to induce repair mechanism, that have a clear-cut, significant improvement in cognitive function, in the symptoms related to the post-concussion, and if you have PTSD, also with related to that. How do we work? We usually give, if it's a soldier or civilian individual, we give time for spontaneous healing. If there is no spontaneous healing after 3 months or 6 months after the injury, then we're starting with the evaluation. Then we see that there is persistent symptoms. We do the evaluation, we look at the brain, we're doing a combination of anatomical and metabolic imaging, and if we see the wounds, we treat him. The protocol that we use is 2 atmospheres, 90 minutes, air breaks for 5 minutes every 20 minutes, and we're giving 60 sessions. It seems that for severe cases, we need to give more, as Lynn, who sits here, have demonstrated in his last study that 80 sessions are better than 40 sessions. We don't know yet what is the optimal protocol. We will probably need to find some biomarker that we can trace, which is not only brain imaging. We are working on that. It's still not cooked enough and not ready enough, but we start with 60 sessions. That is concussion and PTSD and post-concussion syndrome. How about PTSD? I must tell you that for somebody like me, if you would have come to me 15 years ago and you would have told me that I will deal with PTSD, I will tell you, no way. This is emotional stuff. This is not me. This is my wife. She's a social worker. She speaks with people. I'm dealing with biology, with physiology. That's where I am. Okay? But along the years, I have started to see that I might be mistaken. And and I enjoy finding my mistakes. Of course, we have the privilege because I have a research unit, I'm a scientist, I have colleagues, I can look inside. And I think that what convinced me the most that this is indeed a biological injury, this is the model that we have on rat model, a PTSD model on rat. How do you do a PTSD to a rat? You take the rat, you put him in a cage with the urine of a cat for 1 hour. You don't touch the rat at all. That's it. And then a couple of months after, what's good in rats is that you can take the brain out. And you can look at the microscope. And I see a wound. I said, oh my God, it's a wound. And if you will look here, you can see here, these are neurons. Here you don't see them. Here we are looking at COX-2 expression. And here you can see that the COX-2, which is usually being activated in inflammation, is going up. You see chronic inflammation. You don't see a tissue. And this is a wound. And when we saw that, we say, oh my God, we are dealing with a wound. To understand how the stress is severe, I can tell you a story that happened in October 7. The survivors of the terror attacks, when they were reaching our hospital, we had from them several stories. And the stories were like this. The terror attacks were for almost a full day. And they said, you know, amazing thing happened. My dog, who is usually barking on somebody who walks in the next street, didn't bark at all. And the babies didn't cry for hours. They fell asleep for hours. And we all know babies, they're crying all the time. And we all know dogs, they're barking all the time. So what happened? How come they are not barking for hours, and how come the babies are not crying? And this is the fear response. Usually when you see fears, you become arousal because you want to fight back. And then we have the fight or flight phenomenon. This is the normal biology. This is what nature have brought us. That's what we are doing. But if it's more severe, then we have a kind of collapse. The body goes into freeze. In the extremities, it can go into collapse, total collapse. What happened? Think about somebody in nature, an animal in nature, or a woman that is totally terrified because now somebody wants to hurt her. She tries to fight back, and if not, freeze or total collapse, meaning you are making yourself like a dead person that's not worth dealing with. But this is a completely different biology from all aspects than what we have over here. This is overactivation of norepinephrine, of cortisol in our brain. I can give a whole lecture of what's going on in the brain with respect to that. But this is like, when you are doing exercise, you can do training, and recover. But if it's overstress, even in the bone, we will have stress fracture. And this is overstress in the brain. And we have a stress biological damage to the brain. And this biological damage can be persistent. And if it's not being recovered, then we have the PTSD. And this is exactly what you saw in the brain in the rat model. It's a wound, it's a non-healing wound. And the tissues are functioning in a completely different way. In humans, we can see it with functional MRI. Look at here, we don't need to understand exactly what functional MRI is, but the enlightened area are activate head areas. This is healthy individuals, and these are people with PTSD. It's a wound in the brain, it's a biological wound in the brain. This tissue is malfunctioning. And asking somebody with PTSD to function normally, it's just like asking somebody with a broken leg to run. He wants to do it. He can't. When we are looking at the results that we had in Israel with veterans with PTSD, and believe me, in Israel, with regard to the veterans, we don't save anything. They get anything possible and more in order to make them better. But this is the results that we had in Israel with regard to PTSD with all available treatment that you can think of. It's terrible. We are not doing good. And then we realize we need something else. For biological damage, we need a biological intervention. For damaged wounds, we need to repair the wounds. And that's where we started with our first study on PTSD patient. We took veterans. By the way, we have two research lines. One of them is civilian-related PTSD. The other one is military-related PTSD. I will not touch the civilian. I'm touching now the military-related PTSD. We took veterans, combat. With PTSD, it has to be pure PTSD. Without concussion, without blast, without TBI, pure PTSD, which was very challenging to find appropriate candidate for that. And then we randomized them into two groups, treatment and control. The control here was not placebo. The control here, that's the first study, was continue with the standard treatment that you get. And those are the patients. Now look at the time. The average time after the acute exposure, insult, was 11 years. They got any possible treatment that is available today and more, but they didn't recover. And then we took them into the protocol, the HHP, as you know. I can change the phrasing. And this is what happened. You can see a significant improvement in the CAP score. You can see that 50% of them at the end of the treatment didn't met the PTSD criteria anymore. And that happens together with repair of the wound in the brain. And that's all we do. We are dealing with wounds. That's our business, wounds repair. It happens to be that these wounds are in the brain. Okay. This is before and after. And see the correlation between the changes that we see in the brain to the clinical symptoms. They are going hand by hand, just like any other wounds. And once we have this, we initiate the second study. This second study was, again, treatment-resistant PTSD, randomized them into two groups, but this time we had a placebo, a sham group. I must tell you, one of the horrible things that you can do to PTSD patient is bring him 60 times into the chamber as a sham. Okay, the ethical issue related to that are unbelievable, but we got the approval to use a sham. It was not easy to convince the ethics committee that we need to do that, but we bypassed that. And we evaluate them at the end of the treatment and 3 months afterwards. This is the control group, the CAP score. This is the score that we use for PTSD. And this is the treatment group at the end of the HBOT and 3 months afterwards. Again, we can see the relation to the wounds that we see in the brain with functional MRI, which is special analysis. So it's repair. But what about the long-term consequences of treating those veterans? And we did a follow-up of 2 years. And the amazing thing that you can see is the results are 2 years are not less good than the results at the end of the treatment. I must tell you, they are better than what we had at the end of the treatment. People are discontinuing with their medication, they're gaining back their normal life again, employed again, getting married, having children. You're changing the biology. You change the biology, you change the potential, you see the results. And then we did a post-hook analysis to understand who are the patients that benefit the most 2 years after. And there is a correlation. We can see that you need to go over a threshold of 35% improvement in the symptoms. Once you are going higher than this threshold, improvement of more than 35%, then the results for the long term can be even better than the results that happens when you're giving the treatment. And that's the reason, just like any wounds in the legs, once you repair the wounds, you are reaching 80% granulation of a tissue, the wound will be repaired. And when the wound is repaired, you can play football again because your leg is okay. And this is here also. You can go back with your life again, the game of life, and enjoy the environment that happens around you. So our understanding is that, and this is a summarized line, that we can actually trigger a repair mechanism in the damaged tissue, the damaged cell, and then we see the results. When people are coming to me and asking us today what PTSD is, and we have Karen over here, she's heading our PTSD program. You can raise your hand. I don't know how she can manage, especially after October 7, all the unbelievable amount of people that are coming with their stories. But she did. And when you will ask Karen, and I believe Karen, so what I'm saying now is what Karen is saying, what PTSD is. PTSD is a problem of memory, of how we encode the memory. If we take 2 soldiers who were exposed to the same event, one of them developed PTSD and the other one didn't develop PTSD. What is the difference between them? The one who didn't develop PTSD, the event is well encoded. It has a date, it has a time, it's part of your past, but it's past. And if you will take somebody who is suffering from PTSD, he's still living the event. The event is not being encoded. It doesn't have a date and time, so he still live it. And if we want to use some professional language, we have 2 kinds of memory. We have the implicit memory and we have episodic memory. Episodic memory, it's the time and place that happened yesterday at 10 o'clock, and that's what is. And if you speak about the implicit memory, is the emotional memory of the event. It's what I felt, what I'm feeling during the event. How I feel the whole event. And when the episodic memory is not working, then we are still living the event again and again. And any small trigger can trigger that event. Think about a veteran who is going with his child to the Luna Park. The child, they are waiting online to buy an ice cream. For the child, it's a great event. I mean, the Luna Park, fireworks all over, a lot of music around, a lot of people around. Amazing place. But for the father with the PTSD, he's in the battlefield. He's in the battlefield now. So how do we know that somebody has recovered from PTSD? When they are saying to us, the past has become the past. It's not that the event disappeared, but the event has a time and place. It's part of a history. For the good and for the bad, it will affect his personality and how he behave in the future. But the past has become the past. An amazing thing that happened during the treatment, if you are treating PTSD patient, and it might be possible that you are treating a PTSD patient because he had a wound in the leg of post-radiation injury. What happened during the treatment is recovery or surfacing of inaccessible memories. Because we activate the hippocampus. And then the memory are being surfaces. And that person will feel like he have worsening of the symptoms. It's not worsening, it's part of the repair mechanism. Just like you have a wound in the hand, during the healing, it's been shrinked and you feel pain. The same here, shrinking in a different area in the brain. And then the memory are surfacing. And when we look at it, you can see the time event when the memories are surfacing. And if you want to treat PTSD, you need to know how to handle this. Because otherwise, he will stop the treatment over here because he feels worsening. Suddenly, the whole event is going up. You need to say it from ahead that it might happen. That's part of the healing. Now, that has also a huge potential. We are privileged to have a grant from the global arm of the Navy, which are interesting. Okay, so your treatment protocol is enabling surfacing of inaccessible memory. But can you do it faster? I want the surfacing of the memory. I need the memory now. I need it today. Because I need to know what happened during that event. And this event is not accessible for this individual, but I want the event now. So what we are doing, we are trying to increase the gap between the hyperoxic to the normal period. So what we are doing, we are comparing standard treatment with HHP, the hyperoxic-hypoxic paradox, to a protocol where we are doing hypoxia of the hippocampus. How do we do hypoxia only to the hippocampus? We ask the people, we are doing exercise tests, we see the anaerobic threshold during the exercise test, and then we are bringing them to the anaerobic threshold and we give them a cognitive mission that's supposed to be related to the hippocampus during hypoxia, and we see if that's declined. And we want to see whether the combination of the two will enable surfacing of the inaccessible memory earlier. We don't know if it will happen, yes or not, but this is the general com. To make a long story short, there is today huge amount of clinical data related to PTSD. There's nothing like that with any other intervention. Any other intervention. And all the interventions that are being given today to the soldiers, to the relevant, are not even close to this amount of data. Now we are in the US. Every day in the US, we have something like 20 soldiers who committing suicide. My God. We have effective treatment. We are in the US. Well, what's the problem? These are the veterans. Just take whatever we are using. You know what will happen if it was happening in Israel? 20 soldiers committing suicide per day. It was all over the news. We were on the street. We were fighting. It's impossible. We need to stop it. We have an active ingredient. We are doing that. That's the most powerful thing. None of the psychiatric medication is doing even 5% of this. The fact that there is no pharmaceutical company over here that will push and do it, we should do it. It's our soldiers, it's our veterans. See people in uniforms over here. Really? How do we do that? People with PTSD, you don't just take them into a chamber. you know they need special care. It has to be a multi-place, not a monoplace, with a tender inside, that they can take care of the inaccessible memories or emotions that are coming up during the treatment. You need to have a trained staff that knows how to deal with that. You need a psychologist, you need a neuropsychologist, you need a psychiatry on the site. This is rehabilitation on extra steroids. Everything is happened too fast. It's impossible that everybody buy monoplace and take so many insights. Ridiculous. Go in the US. You have the military, the best military in the world. You don't give up on soldiers. The treatment protocol, at least 60 sessions. Nothing happened with 10 and 15. And don't say I have only 10 treatments. That's what I get funding for. Don't start. If you're not given the full course, don't start. You may end up during the recovery of the inaccessible memories, and everything will be lost, and you will have the opposite result than what you're supposed to have. We have to stabilize the patient before. Take the benzodiazepine out, stabilize their medication, evaluate the resources during the process. It's a journey. It's not just in and out. You're taking them to a journey. The good thing in the journey is that they are getting better. From October 7, this is the combat-related injury that we have treated. As said, we are treating around 400 patients per day. We have 177 acute combat injury, and you saw the level. When I'm saying acute combat, it's what you saw. This kind of injury. Each one of them deserve a whole specialty. We have increased the amount of veterans that we treat, ambulatory, PTSD and post-concussion, from 200 per year to 500 per year. And civilians, we have already treated more than 800 civilians who were exposed to the terror attack that happened in October 7. They were exposed to events that usually even soldiers are not meeting in the battlefield. If you choose to treat that, the Sagol Center, it's not hyperbaric. It's a center where we treat people. And we must not forget that. We are not giving hyperbaric. We are treating the patient. And you have to give the patient everything that is needed. If it's an intensive care patient, you need all the intensive care team to be with you. If we are dealing with wounds, we need the orthopedic, the plastic, the wound care setting. We see the wound. Not somebody else is saying the wound and refer us the patient. When we get a patient, we're saying we are taking care of the patient. If we are dealing with PTSD, we need a psychiatrist. We need a psychologist, the neuropsychologist. We need to train the team to know how to handle this population. We need to have the imaging that enable us to see what's going on in the brain. The same with post-concussion. It's a setting of treating a patient. It's not a chamber, it's a treatment protocol. The patient is us, belong to us. We will take care of him from A to Z in the same location. That's how medicine should look like. That's how we would want us to be treated. This is the center that we have. These are those two buildings. In the ground floors, we have the chambers that looks like this. The rehab, the MRI, all the settings that we need, it's all here. That's how hyperbaric centers look like. Before I will finish, I should finish. Before I will finish, I want to give you some touch and feel on how the real people who are suffering from what we describe now looks like. So usually I don't do that, but I will let you see a video of how it looks.
6:30 בבוקר אנחנו שומעים פיצוצים מטורפים. ואז היא באה הבנו שברחבי בארי יש מאות של מחבלים.
I was walking down the street in Jerusalem, and all of a sudden I noticed that I can't hear anything.
נכנסנו לעזה, הגענו לשכונה הראשונה, הכל היה שקט, ופתאום ברגע אחד, בום.
מישהו נרדם במגדל שמירה ונכנסו לבסיס. כל העיגול של הכוונת ברזל, אני רואה את הפנים שלו.
Then I saw this cloud of debris or smoke that made me realize it was a suicide bomber.
אני מסתכל בפריסקופ להבין מאיפה זה מגיע, ופתאום אני מקבל טיל שמגיע לי ישירות לתוך הפריסקופ.
יריתי בו כדור אחד, ראיתי אותו נופל.
שמעתי אותם נאבקים על החיים שלהם, והיינו צריכים לעזור להם.
Severe emotional stress can actually cause biological damage to the brain. This biological limitation, injury, malfunction in brain tissue, that's become the bottleneck that prevent us from getting back to full functionality. And in order to open this biological bottleneck, we need a biological intervention. And this is where the new protocol of what we call hyperbaric oxygen therapy comes into the game.
הייתי קרוע מבפנים, לא מדבר עם עצמי, מסתובב עם תחושה של דם על הידיים כל הזמן.
Every time I go through urban environments, I had to clear the room, or I always check for snipers on the rooftops.
כשאני נוסע ברכב והגשם מטפטף על השמשה, הגשם מזכיר לי את הטיל שפשוט הגיע והתפוצץ לי בתוך הפריסקופ, לתוך הפנים.
כשנחום כן היה מגיע להופעה שלי, כל פלאש וכל הבהוב של אורות הבמה, בווליום החזק, כל הדברים האלה היו זורקים אותו במקום אחר, הוא כבר לא היה בהופעה בתל אביב, הוא היה בשכם.
בשנייה, ברגע, כל העולם שלך נחרב. זה לילות בלי שינה, חוסר תיאבון, בחילות. האבל הוא גדול.
We are playing with the pressure and the oxygen concentration, going up and down. And by doing that, we are generating a sense of lack of oxygen at the cellular level, even though we have extra oxygen. All the repair mechanisms are being activated because of that. Stem cells start to proliferate in the brain, new blood vessels start to regenerate, and for the first time we can see repair of non-healing wound in the brain. And the symptoms related to that area, the symptoms will resolve because we have actually repaired the core responsible for the symptoms.
אני באה הנה 5 פעמים בשבוע. אני עכשיו בטיפול ה-33 מתוך 60. יש שיפור בתפקוד, רמת השינה, אוכל, חיוניות.
חשבתי שלעולם אנשים לא יוכלו לאהוב אותי, שלעולם לא יוכלו לראות אותי כמו שהייתי רוצה. בזכות התא לחץ הרבה הגיע למקום שאני יותר אוהב את עצמי ורואה אותי ומסוגל להבין שגם מסוגלים לאהוב אותי ולקבל אותי.
תקופה לא ארוכה אחרי טיפולים בתא לחץ והכניסה ללימודים, גם הבאנו את מאיה, כאילו, העזנו להביא ילד לעולם.
That's the end.
I'm sure there's a number of questions for Dr. Efrati. Dr. DePena.
Good afternoon, Dr. Efrati. I've been following your work. Really, I need it. Good afternoon. I'm Dr. DePena. I'm a fellow from LSU in the U.S. Navy, one of 6 right now, soon to be 7. I've been following your work since I became a UMO in 2014, and I was more interested when I did my fellowship in 2018. I think this is the first time I hear you bring the whole context of the treatment in general, not just hyperbaric medicine, but it's the whole team concept. And my question to you is, has there been any study where the patients receive hyperbaric oxygen alone versus hyperbaric oxygen plus the cognitive behavioral therapy and all the mental health services? I'm not familiar with how you, what are the protocols in Israel for the standard of care for PTSD and TBI, but is there anything comparing just hyperbarics with those who decide to do hyperbarics and continue the standard of care? And another question is, with the volume of carbon monoxide poisoning, I am sure that you have had pregnant patients who have required hyperbaric medicine, and there's always a question of OBGYN physicians who are reluctant to send intoxicated patients to the chamber because there's no studies of the aftermath of the baby once it's born and has been affected by carbon monoxide poisoning. Sorry for the extra question.
Okay, I will start with the first question and let Lynn answer you about CO intoxication, because even though we had a lot of this, it's not in the amount that other centers have. When we are doing a clinical study, then the only intervention that we add is the treatment of the hyperbaric oxygen therapy. The treatment that we give for PTSD is for patients who are treatment-resistant PTSD. Treatment-resistant PTSD. They have been to psychotherapy, they receive medication if they need, they receive anything that is advisable today, but still they are continuing to suffer mostly from intrusive symptoms, and all the other symptoms are because of the intrusive symptoms. So those are the patients that we take. And again, hyperbaric should not be the first line of treatment. Should not. Okay, maybe in the future we will find that it is, but currently it's a limiting resources. So if you are doing evidence-based medicine, we are speaking about treatment-resistant. You saw in the first study 11 years since the event. During those 11 years, they received everything. They continued to take psychotherapy until the hyperbaric and during the hyperbaric. I must tell you that when we are treating PTSD, treatment-resistant PTSD, the results are better than results that we have in the clinical study. Because in the clinical studies, it's only hyperbaric without team that knows how to deal with that. And when you are doing that not as part of a clinical study, you have the privilege that you can do everything that you think is good for the patient. So the results are much better than the results that you see in clinical study, even though the results in clinical study are amazing. There's nothing like that, any intervention that reached that level. Regarding CO with pregnant women, it's the standard. The limiting for carboxy is 20. Until now, I'm not familiar with any terrible thing that happened to the baby when you are treating a pregnant woman. Not in Israel, and Lynn, correct me if I'm wrong, probably not in other places in the world that we are familiar with. So generally, it's safe to give at least one session of 2.8 at treating carboxy, treating CO intoxicated women.
Go ahead. Can I go ahead?
Thank you very much.
Whoever wants to ask a question, you can go to the microphone.
Okay,
Yeah.
can I go ahead?
Yeah.
I have the mic here. Can I go ahead? All right, so my name is David Ajayi. I reached out to you, thank you, for 3 years ago when I was trying to design a study in Fargo, North Dakota on post-concussion and in civilian population. And I got the protocol, you sent an email to me. We corresponded via email. Well, my question for today is simple. Sometimes in research, it's very important to know the people that do not respond, right? So for example, PTSD or post-concussion, are there reasons, or have you found cases where people do not respond, non-responders, regardless of the 60 treatments or more, and they don't improve? And if it's true, because I don't want to believe that all 100% is 100% success rates, right? So the non-responders, why are they not responding? So is it a case of the part of the brain that is affected? For example, is it the hippocampus, amygdala? Is because the reason why I'm asking this question is we are yet to publish our study. It's currently, we're done looking at our data, and we are realizing that the brain itself is complex, and all parts of the brain are not the same. In a way, for example, if you have a wound in the foot, a venous stasis ulcer is not the same as an arterial ulcer. So some parts of the brain are responding, some parts are not responding. So my question is that the same? Have you found out that both in PTSD and in concussion, the parts of the brain that is, for example, if a patient has problems with vision, they improve. But if they have problems with learning, disability, they do not. Immediate memory, they improve, but delayed memory, they do not. That's my question.
That's a good one. And I will start with somebody that everybody knows. Let's say you have a wound in the leg.
Yeah.
Okay, the way we evaluate which wound is suitable for the hyperbaric, we are doing TCOM. Okay, you are measuring the oxygenation. If it's below 40, you move forward to the next step, take them into the chamber, see how much the oxygen is increased while you're inside. If it's above 200, you have a chance of 80% or more, and then you treat. So what we need is we need a TCOM for the brain. Okay, so we can characterize the injury that you have at the cellular level,
okay,
at the tissue level. For that, what we are using is we are using the combination between anatomical and metabolic imaging. We are using the ECD, okay, as a tracer. And then, if you see an area that anatomically is not damaged, meaning is still there, you have the infrastructure on which the stem cells can proliferate and grow. But you see that the tissue is malfunctioning with respect to metabolic activity, and this region in the brain correlates with the symptoms that you want to treat, then you have, just like the TCOM, more than 80% success rate, meaning setting up the expectation from ahead with the patient that's sitting beside him. But if somebody have a symptom that is totally unrelated to that area, then it will probably won't change, just like in the legs. But even if we will have the best TCOM in the world, it will still never be 100%. This is biology. What's good in biology is no matter how good we are, we can get better. Okay?
Yeah.
So that we can always think how we can get better. So that's what we are doing now. That's what we are doing now. It will never be 100%, but we are reaching to a better and better point. So the SPECT, or metabolic imaging, is classical. Another thing which is important is how do you diagnose PTSD? Okay? Today the diagnosis criteria is based on an interview, on subjective symptoms that the patient gives you. And many of the people who will sit in front of you may have some interest. Some of the soldiers, for example, soldiers who are elite soldiers, okay, will try to hide the symptoms. Some of the soldiers will enhance the symptoms because they want to stop. I always said the soldiers can be divided into two. There are the people that will do anything in their hands to stay in service, and there are the people that will do anything in their hands to get out of service, okay? So you have the two extremities. So one of the things that we are doing now, and Karen is leading this project together with colleagues from the Weizmann Institute, is that we are trying to find the biological fingerprint of PTSD. So you can diagnose PTSD in objective fashion, just like you're going to the ER and saying you have a chest pain. Nobody will diagnose you as suffering from myocardial infarction based on your chest pain, okay? It might be that you have problem in the lungs, just a panic attack, problem in the muscle, in the bones. You will do ECG, evaluate troponin level, enzyme level, and based on that, you're making the diagnosis. So hopefully in the near future, we will be able to make the diagnosis in PTSD like that. I must tell you that already now, we are in more than 80% of the cures of the cases, we can make the appropriate diagnosis only by brain MRI, things that we measure in the brain. 86 last week? 87, yeah. Karen, correct me. Last week, 87. Once we will go above 90%, we can give the tool to everybody. And then we will try to speak in objective fashion on biology, what's happening, what we are dealing with. And then we can improve and improve and improve. Hope that answers your question.
Well,
yeah. We will continue afterwards.
It does. Thanks. I'll see you later.
Yeah.
Thank you very much. This was very interesting to me. I'm Anna Grodecki from Canada. I'm a Duke Hyperbaric Fellow, but over the past year I've also been the interim director of our mental health directorate. So this is a very interesting presentation. You spoke about the suicide rates and you referenced the US military. Obviously we also have our own, but we find that it is depression rather than PTSD that's more highly associated with death by suicide, at least in our military. But much like the PTSD you spoke about, it is also a treatment-resistant chronic depression. And I was wondering if, since it is things like chronic inflammation, whether there is any plans to look into that sort of chronic treatment-resistant repression to see whether it also might be a biologic wound that could be healed or treated by hyperbarics.
So, you know, what happened now, it's a whole area that was open, okay? And we don't know. There are plenty of things that we need to do. We will get to that. But we still don't have answer to your question. What I can tell you, we should definitely not look at the symptoms, but rather look at the primary cause that's responsible for these symptoms, but we don't have answer to you. Unless Karen wants to say something, go ahead, Karen. Yeah.
So when it comes to post-traumatic depression, the response for treatment is very, very high. Actually, it takes time till the post-traumatic symptoms remit, but sometimes depression responds within days or weeks. It may have something to do with mitochondrial activity that improves immediately when we start the treatment, but we get very high response rate in post-traumatic depression. Although we don't know anything, we never studied major depression.
Thank you so much.
All right, thank you very much for this very interesting presentation. I wanted to ask something about the molecular mechanism that you exhibited earlier. Since HIF protein is also known to play a role in cancer promotion, I was wondering whether you consider long-term studies to investigate potential negative effect of the therapy. And the second question related to that, whether do you see any individual responses to the therapy?
Okay, so the first question relates to cancer. What's unique in cancer cell is their metabolism, okay? Cancer cells are doing anaerobic fermentation of glucose. Their mitochondria is different, meaning they are utilizing glucose without oxygen. Meaning that cancer cells, there is a Nobel Prize on it. This is what we call the Warburg effect. Okay? So it means that cancer cells have advantage over the normal cells in hypoxic environments, and in most solid tumors, I don't speak about the hematological tumor, the environment is hypoxic. The induction of VEGF and HIF in cancer cell, it's abnormal triggering, it's abnormal angiogenesis. What we can say clearly, because many post-radiation patients are being treated with hyperbaric, we can say clearly that hyperbaric oxygen therapy doesn't make the cancer to grow. What we cannot say yet is whether hyperoxygenized environment it's a good treatment against cancer. That we cannot say. It might be possible that combination of ketogenic diet together with hyperbaric oxygenation can achieve a biological, but we can say clearly it doesn't cause any cancer to grow. But let's stay with that, and the other statement that needs to be proved.
Okay, thank you.
Yes, very interesting talk. One of the most devastating sequelae of traumatic brain injury is chronic traumatic encephalopathy, which is the aggregation of tau proteins, basically, that ultimately result in neuronal death. And this seems to be driven in part by chronic inflammation, which produces physical changes in the brain, in pH, in salt concentration, that accelerate the molecular aggregation of tau. So I was wondering if you have identified any changes in or any effect of the hyperbaric oxygen therapy on the markers of chronic inflammation.
If you speak about, you're asking about amyloid or tau in the brain, that's your question?
Yes, amyloidosis in the brain,
okay,
primarily associated with tau.
So we haven't evaluated tau or amyloid in the brain of post-concussion patient. That we haven't done. We have a study that is ongoing now for what we call prodromal Alzheimer, meaning patients who have cognitive decline, who have amyloid in the brain, but they are still not dementia. In animal models, the results were very good. In preliminary study that we done, the results look very promising, and now the clinical study is running, so we will have to wait and see. But we haven't evaluated amyloid in TBI or post-concussion.
Hi, Shai. Thank you very much for your very nice presentation. In the fact that you have had quite a high number of PTSD patients, did you ever try to reduce the weekly therapy from 5 to 3 maybe in the face of limited hyperbaric treatment places all over the country, because you have long-term neurological sequelae, and you told me that you face long-term improvement, but not fast-track improvement. So have you ever tried to use 3 times a week protocol?
These kinds of questions are being up all the time, whether free time, 10 sessions instead of 60 sessions. You're going to have a presentation today about, after we did a study for a post-COVID patient, okay? Yeah. Which was 40 sessions, but now we give 60 sessions, and somebody done 10 sessions, and surprise, surprise, it doesn't work, 10 sessions, okay? Nothing healing, 10 sessions. It took us a lot of time. It's not a history class, so I will not give you all the history how we came to 60 sessions. To make a long story short, nobody compared 3 sessions to 5 sessions per week. Nobody compared 2 sessions to 5 sessions. Nobody compared 4 to 5. Etc., etc. So we don't have the data. But we do have currently is a protocol that is working. And everybody who wants to change something should compare it to the gold standard. And now it's the time to find the optimal protocol per individual, okay? But it's a different phase. We cannot say that anymore hyperbaric doesn't work, I need to prove that it's working. It's working, point. Now let's compare different protocol and see which protocol is better. We need an answer for that. We don't have it yet.
So you haven't done it yet?
No.
Okay,
we have time for one more question. Thank you. I found the presentation very fascinating and uplifting and moving as well. In the dilemma of monoplace versus multiplace, typically within a multi-place chamber, you're compressing that chamber with air, and then the patient would breathe oxygen through a mask versus a monoplace where it's compressed with oxygen, are there significant elements in using multiplace versus monoplace where some patients may not have access to a multiplace chamber?
So they should, okay? And everybody, any change in the protocol, you know, here in the US, we see a lot of sacks full of air with compressor. People buying that to home, they are buying tube, they are increasing the pressure a bit, and I see people are using our studies, and I see my face in different locations, totally unrelated, with tubes, with sac, and they're saying, I'm giving a Efrati protocol, it's working for that. It's ridiculous, it's fake, okay? So if you want to use a certain protocol in monoplace and say that it works the same, you need to prove it. Until it's not being proved, if you are giving a treatment based on something that was proved, you have to give the same thing. It's like a medication, okay? You have a certain medication, a certain capsule with chemical entity inside. And now you're saying, you know what? I'm still using the capsule, but I want to change the ingredients. But I'm still using the capsule, so I'm just giving the capsule. It's a different ingredients. It's a different ingredients, different activity. It might work better, it might work less, but this is not the same drug. It's a different drug. The fact that you have a capsule in both of these cases, it's totally different drug. You want to use it, prove that it's working. And unless it was proved, it's a different drug, different chemical entity, different effect. You cannot say that you are giving that based on this study. You have to do another study, prove that it's the same, and move forward.
Thank you.
Outstanding presentation. Jeff Jones from Baylor. Interested in your comments on treating radiation-induced hemorrhagic cystitis with hyperbaric medicine, and what is the induction protocol, and then what kind of maintenance do you need to prevent the future bleeding episodes?
Wow, that's a whole lecture by itself. To make a long story short, it's working, as you know. One of the things that happen, if you stop the treatment before you have full recovery, you may have relapse. So if you are monitoring only the bleeding, you might see after 20 sessions that the major bleeding resolved, but the tissue was not fully recovered, and then you will have a relapse. If you are monitoring the tissue and see when the tissue is recovered, usually it will not be less than 40. I'm saying usually because the damage is totally different. If you're treating until you have full recovery, then you probably won't have relapse, but it might be possible that you have. But this is a whole lecture. I don't think I should get into that now. I would gladly give a lecture on that. But
okay, well, for next year, we're going to tap you for that one.
Yeah.
Thank you.
Shai, well done. Eric Kinwall, God rest his soul, would be most impressed with your talk. And this is, of course, the memorial lecture for Dr. Kinwall. But in the study you mentioned that, of course, I authored along with others in 2025, just a few months ago, the first phase of that study was monoplace chamber only. The patients breathed oxygen at 2 ATA, corrected for altitude, and they received 5-minute air periods identical to what you do in the multiplace by using a scuba regulator. And the biggest effect in that study was in the first 40 sessions, as you might recall. And then when we did the extra 40 sessions, that was open label, all in the multiplace chamber, again following your protocol. We did this out of scheduling, logistics, and to help protect the blind. So it's probably not quite fair to say there's no evidence, because this recent paper, just out in January, the first half was monoplace.
But with air.
Yes, with air. So it was 100% oxygen.
He was asking about using oxygen 100 all the way.
And then, well, yeah, that's a different talk, isn't it? Because let's go back in time. When you first started, 1.5 ATA, 60 minutes air, and that was virtually all the stuff that we did in the series of DOD studies, well, with the exception of what happened at Brooks, of course. And so again, that's a whole totally different session. But yeah, so anyway, monoplace I think can be done. We did it. The dosing of oxygen should be virtually identical, and the dosing of air, if you do air properly, we did not do air by using a reservoir face mask and high flows and all that. We used scuba regulators with a nose clip for 5 minutes, just as you have shown us. Thank you, Shai.
Thank you, Dr.
Thank you very much.